Hi, friends. Thank you so much for joining yet another very, very interesting topic on wound care and peripheral vascular disease. We've got an esteemed group of panelists who's going to be discussing, and I'm looking forward to this. As always, we try to bring you cutting edge um, topics which are of interest to everyone, irrespective of the specialty you belong to. So this time, Dr. Tarak Vasavada is out of town, out of country. Dr. Atul Prakash is the CME Vice Chair. He's there. And this session will be moderated by Dr. Somya Nervetlu, who is a cardiothoracic surgeon and she's going to be introducing the speakers and the topics and moderate the question and answer session. And I really appreciate all of you joining. And remember, we're going to keep it absolutely the same time every month. It'll be the second Sunday of third Sunday of each month at 2 p.m. Eastern time. So over to you, Soumya. Um, Take it from here. Thank you so much again. And I'll come back at the end of the talk to give you a little preview of what's to come next time. So over to you, Soumya.
Thank you, Dr. Chakrabarty. As Dr. Chakrabarty mentioned, I am a cardiovascular and thoracic surgeon. I actually have a lot of vascular surgery in my practice as well. And I'm actually the current treasurer of AAPI, of course. And first of all, I'd like to wish everyone happy Naraka Chaturdashi and happy Diwali greetings for the holiday weekend. I hope everyone's celebrations are going well, and we appreciate your taking the time during those holiday time with your families to join us for the CME. This session is our Limb Salvage Summit, and we have actually three esteemed speakers joining us today. We have a cardiologist who has some endovascular experience, is going to be talking to us about a little bit about the background and the kind of laying the platform. Then we have Dr. Jaya Shah, who is one of our own past presidents who has extensive experience in wound care. And then we have Dr. Krishna Manava, who is a vascular surgeon. So I'll start off introducing Dr. Anand Prasad. He is the director of University Health Cardiovascular Center and Cath Labs and professor of medicine and director of interventional cardiology for the program at UT San Antonio. And he's also an interventional cardiologist at the University of Medicine Associates. He graduated from Louisiana State University School of Medicine in 2000 and completed his cardiology training at UT Southwestern, and then went on to do an interventional cardiology and endovascular fellowship. He's been serving at UT San Antonio and has been extensively involved in interventional cardiology fellowship program and in the vascular medicine clinic, working with podiatry and interventional radiology. So it is with great pleasure that I turn this session over to Anand Prasad to get us started.
Thank you so much. I'm going to share my slides. Okay, so my talk today is focused on really setting the stage for the talks subsequent to this. And we're going to talk about the epidemiology and diagnosis of PAD. And I'm going to walk you through a little bit of my journey into the vascular space. So some disclosures. So a little background about me. I did my training at Parkland Hospital in the late 2000s here. So 2000, 2007, internal medicine cardiology fellowship. And then I moved to UC San Diego, where not only did I do an interventional cardiology fellowship, but did an endovascular and vascular medicine fellowship. And actually was mentored by a vascular surgeon in vascular imaging, and really began to explore the world of diagnosing and treating peripheral arterial disease. I stayed at UCSD on faculty for 3 years, and I wanted to treat vascular disease, and I had a big concern. Was there any vascular disease in San Diego? And in fact, I had to drive 2 hours east of San Diego to El Centro, California, in the Imperial Valley to find a lot of vascular disease. Driving through the mountains every other week to go to a wound healing center, and that was the Imperial Valley Wound Healing Center. And there, I supervised hyperbaric dives. I did my own wound care, ordered and read vascular studies, and then scheduled patients for their angiograms and endovascular cases. And that really gave me a deep understanding of the complexities of diagnosing, treating vascular disease, particularly patients with chronic limb-threatening ischemia. So there I worked as a cardiovascular wound care doc for 3 years, and then moved on and joined University Health in Texas in 2012. And in San Antonio, I did not have to drive 2 hours. We had a lot of PAD in San Antonio, a lot of diabetes. And so this is the first part of my talk. I want to talk about the epidemiology of PAD, and I'll give you my perspective as a practicing physician in Texas. So I think all of us here on this call know about the epidemic of peripheral arterial disease, with 10 to 12 million of adults affected. And we project that this epidemic is going to get worse as the population ages and the cardiometabolic risk factors of our nation worsen, including diabetes prevalence. And we know that the global prevalence is also increasing. It's important to emphasize that most peripheral arterial disease is asymptomatic and is subclinical, with about 20% of patients developing symptoms over time. So, 1 in 4 people get symptoms. The vast majority of people who get symptoms will have limb symptoms that are either atypical or typical of claudication, with a minority of people developing actual chronic limb-threatening ischemia. However, CLTI, or chronic limb-threatening ischemia, is, of course, the most dramatic presentation of peripheral arterial disease, and the one that we most fear, leading to amputations. In fact, these data have been well published and presented on throughout different forums, but we know that there's an amputation belt within the southern section of the United States. You can superimpose an obesity belt, a diabetes belt, a chronic kidney disease belt, but the southern region of the United States are particularly vulnerable to the ravages of diabetes and complications. Historically, we've had data suggesting that non-traumatic amputations in the United States have decreased over time, and that's potentially a function of increased awareness and treatment of peripheral arterial disease. However, our own data in the state of Texas that we published looking at amputation rates and revascularization have demonstrated that in Black here, major amputation rates have remained relatively flat, if not increasing, in Texas, with a decline actually in endovascular or surgical revascularization procedures. So there's a lot of disparities and heterogeneity in treatment of peripheral arterial disease, as well as amputation rates in the country. Within Texas, we know that diabetes is particularly rising, and by 2040, you can see the projected total number of cases of diabetes. And there's a large demographic shift with increased number of Hispanic patients projected to have diabetes by 2040. Even within the state of Texas, there's a gradient of diabetes. This is a graph demonstrating diabetic mortality. And you can see that compared to North Texas, South Texas has a particularly higher prevalence of diabetic mortality. Similarly, you can superimpose amputations. These are amputation data by county, and you can see a gradation of amputation risk from North Texas all the way down to South Texas. So on top of this, when you have a lot of diabetes, we know that chronic kidney disease is a important disease that develops in these patients, and you can see that the projected increase in CKD worldwide is rising, and 1 in 5 to 1 in 4 women have chronic kidney disease in seniors. PAD and kidney function are closely related. It's not just an association, but there's a cause and effect. And 1 out of 4 chronic kidney disease patients will develop PAD, and half of dialysis patients will develop symptomatic PAD. And you can see that as the renal function worsens, there will be a more higher prevalence of abnormal ankle brachial index. And it's not uncommon in dialysis centers to see patients who are missing limbs. So diabetes and CKD is particularly convergent in terms of severe PAD. Now, our awareness of PAD is quite poor. Public awareness is poor. Under recognition of risk factors and therapy options. There's a huge burden of cost on the healthcare system. We have a lot of opportunities of screening in high-risk adults, pushing smoking cessation, addressing cardiometabolic risk factors, and preventing chronic kidney disease. So let's talk a little bit about the diagnosis of PAD. As we stated before, claudication and CLTI are the two presentations that we are concerned with, and it's very important for practitioners who are not familiar with peripheral arterial disease to understand that the symptom profile should be linked to anatomy as you evaluate the patient. So claudication, classically effort-related leg or buttocks pain, and CLTI, we're looking for rest pain or tissue loss, particularly in patients with diabetes. And the level of disease is going to relate to symptoms. So aortoiliac stenosis is going to be associated with buttocks, thigh, hip claudication. Superficial femoral artery or popliteal disease can give you calf claudication. Infrapopliteal stenoses can be silent. In fact, they may not even be a important factor until the patient develops injury or tissue loss, and then lack of blood flow in the tibial circulation becomes very, very important. Our methods to assess patients can be grouped broadly into a macrovascular or microvascular approach. In the macrovascular section, we commonly use the ankle brachial index. We can incorporate segmental pressures. We have toe pressures and TBIs. And then we have anatomic imaging, which most commonly is duplex ultrasound, CTA, MRA, or the gold standard, which is invasive angiography. There's a host of microvascular tests that are used less commonly by the general practitioners. Those can be skin perfusion pressures, transcutaneous oximetry, and then we'll touch upon some novel imaging techniques. So let's talk about the ankle brachial index, which is perhaps the most commonly ordered test for the detection of PAD. It's a powerful tool in that it can be used to screen, can determine disease severity, provides prognostic data, is non-invasive, reproducible, and relatively easy to perform in the office. To remind everybody, the ABI is determined by the highest ankle systolic pressure in a given limb over the higher of the two brachial systolic pressures. According to the AHA-ACC guidelines, a normal ABI is now listed as between 1 and 1.4. A 0.91 to 0.99 is borderline. Less than or equal to 0.9 is now abnormal, and greater than 1.4 is abnormal. Less than or equal really to 0.6 suggests severe ischemia, and an absolute ankle pressure of less than 50 is considered abnormal. There's been a lot of back and forth about the criteria for screening individuals for PAD with the ankle brachial index. The ABI, the American Diabetes Association, ADA, has been perhaps the most aggressive with ABI screening, but you can see that there's a lot of heterogeneity amongst the different organizations in terms of whether to screen patients or not, and at what point screening may be covered or by insurance companies. It's important to understand that ABI and mortality has a relationship which is U-shaped, such that as the ABI value falls below 1, mortality increases. But ABIs that are greater than 1.4 are also associated with increased mortality. Example of some of the challenges with the ankle brachial index. This is a patient of mine, 67-year-old diabetes, presents with a right heel ulcer. Remember that we're using the higher of the two brachial pressures and then the higher of the pedal pressures on each limb. So if we do this calculation, the numbers don't look so bad. And it's really important to understand that the traditional calculation of the ABI really emphasizes specificity over sensitivity. And if you use the lower of the two ankle brachial index pressures, which is called ABI low, you can get a better look at a angiosome specific ABI value. Not only do we look at the absolute values, we want to look at waveforms, and we want to see how much deviation from a traditional healthy triphasic waveform that we get, so we can have a biphasic or ultimately a monophasic waveform, which indicates not only the presence of potentially a stenosis, but also loss of arterial compliance with vessel stiffness. So the calculations, as we said, are important. And, if you are using these calculations, you should look at both the ABI high as well as the low. We've demonstrated in our data within South Texas that using a specific definition can really alter the prevalence of PAD, and this was in a subclinical population study. So why might you get an elevated ABI? Well, we know that vascular calcium is an important feature of diabetes and chronic kidney disease as well. You can have intimal calcium, which is associated with stenoses, and medial calcification, which affects vascular compliance. Classically, we see the train tracking lesions of medial calcification on plain films or fluoroscopy. And this results in vessels that are very hard to compress and elevates our ankle brachial index measurement. This is particularly important in patients with chronic limb-threatening ischemia, where a normal or seemingly normal ankle brachial index can give us a false sense of security that there is no PAD. In fact, a seminal paper by Sukol et al. Was published in JACC in 2017 and looked at the heterogeneity of ABI values in patients who were undergoing revascularization for critical limb ischemia. And this was derived from the Blue Cross registry data set in Michigan. And essentially what they found was in patients who had known critical limb ischemia and were undergoing either surgical or endovascular therapy for PAD, about a quarter of patients actually ended up having a normal ABI, and a minority of people actually had severe abnormalities in the ankle brachial index, again pointing to the fact that the ABI can miss disease. In this context, we often use the toe pressures, TBIs, and a TBI of less than 0.7 suggests PAD, and that's based actually largely on epidemiologic analyses rather than physiology. But the toe brachial index can be a particularly important value to look at in patients where you're concerned about vascular stiffening. Uh, in addition, other tests that can be looked at to help guide level of disease are things like segmental pressures. I didn't get into plethysmography, but these tests are done less frequently now, but they can help localize the level of disease by looking at a gradient or drop in pressure between segments. So beyond ABI and pressures, we can look at anatomic imaging and hemodynamics. Duplex ultrasound is important because it can provide not only imaging, but also hemodynamics in terms of velocities. And by relating the velocities to established benchmarks for stenosis, we can look at ratios and determine whether or not a stenosis is present. This is particularly important after endovascular therapy or bypass grafts have been placed to follow patients serially. In addition, in patients who have chronic limb-threatening ischemia, pedal acceleration time has emerged as a method to look at the success of endovascular therapy, particularly as it pertains to getting distal blood flow. CTA and MRA are often used. CTA, can help us plan out interventions, particularly if symptoms are bilateral, to understand if there's aortoiliac disease, to help with vessel sizing and to plan CTO procedures. Of course, the presence of vascular calcium can confound assessment of the lumen in these patients. And patients who have chronic kidney disease, there's oftentimes a reluctance to give contrast dye to those patients, although I would tell you that the data for acute kidney injury after CTA is quite poor. So, I don't worry too much about renal dysfunction and CT scans. The gold standard for diagnosing PAD through anatomic imaging is through invasive angiography using digital subtraction. This is particularly an important tool when we are planning intervention out. So, invasive angiography remains the gold standard. Of course, there are risks of, vascular access complications and so forth. So here's an example of the importance of digital subtraction. It can really highlight small vessels and really help define the lumen when there's occlusion or near occlusion of vessels. Important imaging pearls. We've given several talks on this that are online available, but the advantage of DSA and catheter-based angiography is really being able to define all the various vessels, particularly in the pedal circulation, when we're planning interventions. So just showing all the different views that we use to define anatomy, particularly when we're getting pedal access or working distally. We use those angiograms and we can relate them to ulcers and wounds on patients' feet, much like a dermatome is related to nerve roots and skin. We use the angiosome concept to relate the tibial circulation and the pedal circulation to where a wound might be, helping us understand where we should focus our energies in terms of improving blood flow. There are additional tests that we can do to look at microvascular circulation. So transcutaneous oximetry is variably used. I still like it as a tool. It really looks at diffusion of oxygen through capillaries at the skin level. We can use it to help determine if wounds are ischemic or non-ischemic. It can guide us in terms of improvements in oxygen levels in the distal circulation after revascularization therapy. It can help us decide if a patient's a good hyperbaric candidate by relating the change in oxygenation at sea level and comparing that to what might be achieved if they get hyperbaric oxygen therapy. And it can also still be used to help understand the demarcation level for an amputation, whether it should be transmetatarsal, below the knee, or above the knee. There's more emerging technologies looking at microcirculation using near-infrared spectroscopy to look at tissue-level oxygenation. In addition, there's laser techniques looking at speckle contrast, looking at red blood cell movement, and looking for areas of hyperemia surrounding wound beds. In addition, there's fluorescence angiography, which combines laser imaging with indocyanine green, again, to look at oxygen levels at the tissue level. Lastly, I'm going to end by having a brief word on venous disease, because we spend a lot of time talking about PAD imaging, but we often ignore venous disease, and our focus is too often just on arterial disease. understanding that the superficial and deep systems both can contribute to pathology related to non-healing wounds. So patients can certainly have normal arterial flow, but still have persistent painful ulcers that are difficult to heal. And venous disease is a really common underappreciated problem in the population. And the common themes for venous disease remain age, female gender, a history of varicose veins, obesity, pregnancy, prior DVTs, and leg injuries. Just understand that we use the SEEP classification to help with our nomenclature as we diagnose venous disease, all the way from SEEP 0 to SEEP 6, which is an active venous ulcer. Duplex ultrasound, at least for venous assessment, is really very important to understand if there's reflux in the superficial or deep systems, with a retrograde flow of more than 0.5 seconds in the superficial system and more than 1 second in the deep system as being significant. Also, very, very underappreciated is compressive pathology, so non-thrombotic iliac vein lesions or nivels. Traditionally, we think of May-Turner syndrome with left iliac vein compression, but more and more we're understanding that this compression can occur bilaterally and not simply be related to arterial compression, but could be related to fibrosis and inflammation in the pelvis and lower back. The gold standard for diagnosis of compression remains venography, so invasive venography and intravascular ultrasound, and coupling those two can greatly improve our sensitivity for compressive disease. Just wanted to give a last shout out to what we're doing here at University Health, where we're building a very comprehensive limb salvage program, working with our podiatrists, wound care docs, and interventional cardiology team. We're off to a fast start in developing this, and we hope to branch out to our new hospitals and work with our vascular surgery colleagues in the community to really make an impact on those statistics that I showed you earlier on amputations in South Texas. So with that, I'll say thank you and conclude my talk.
Thank you, Dr. Prasad. We're going to take questions at the end of all three speakers. So if anyone has any questions before we get to the next intro, please feel free to type your questions in the chat box, and we'll be doing questions at the conclusion. Next, it's my privilege to introduce Dr. J.S. Shah, who is well known to all of our organization. He was one of our beloved past presidents and is currently the CMO of PACT at Northwest VA Health Center. He has extensive experience in the wound care centers, and he is also not only a personal mentor of mine and very accomplished in advocacy. He's the current TMA president, but he's also much cooler than I am with a very active social media presence, with a blog and other, many other things that he keeps himself busy with in sharing not only clinical tips and mentorship, but also in advocacy efforts. So without further ado, it is my honor and privilege to introduce Dr. Shah and let him take over.
Thank you, Dr. Neeravelta, for that kind introduction. And thank you, Dr. Prasad, for starting and putting that on stage so that I can discuss limb salvage. What I will do is use a case to really talk about what Dr. Prasad said and how to diagnose them and how do we treat with advanced wound care. So that's the goal I have. And these are my disclosures. So if you can look at that, and the disclaimers, the views expressed in this lecture are my own and do not represent the opinion of any employer, organization, or affiliated entity. All right, so some disclosures on my book and the free app that I have that you may want to look at. And this is another textbook if you want to look at. So we're going to talk about why we need cutting edge wound care for limb salvage. And we could look at it in the form of a case. This is a patient that most of us have who are in wound care and limb salvage work. That this is Mr. RG, who's a 45-year-old diabetic male admitted to the hospital for infected diabetic gangrenous foot. As you see here, there's a purulent drainage, there's gangrene of the toe. And as you see from the dorsally, you see there is a onychomycosis, hair loss, and there's basically a wet gangrene, which needs amputation. But let's look at psychology of Mr. RG when he's in the hospital. What are these patients with diabetic foot ulcer most fearful of? When they're in hospital and when they're having this necrotic foot or a necrotic gangrene, what they're fearful of is amputation. They're not more fearful of amputation than even death. And that's very important for all of us to understand that when patients get amputation, they're really scared of that. They really want to save their feet. So, if Mr. RG gets a major amputation, what are his chances to survive next 5 years? And you looked at Dr. Prasad's, epidemiology presentation, but you have to remember that every 10, 20 seconds, somewhere in the world, somewhere is getting amputation. Every 20 seconds, while we are giving lectures, a lot of amputations are happening at this particular moment. So again, if you really look at the statistics, as Dr. Prasad pointed it out, that deaths from DFU or DFU-related amputation really exceeds that from prostate cancer, breast cancer, and Hodgkin's lymphoma combined. So that's why we are having this limb salvage summit at AAPI level, because the awareness of amputation and diabetic foot management is so, so, so important. Now think about Mr. Archie. Once he gets amputation, his chances of surviving is pretty low. If you look at the statistics, 11% of them will die at 30 days and 18% of them will die in 90 days. So it's a pretty significant mortality. By 5 years, 68%. Once they get amputation, 68% of this patient will die, okay, and which is pretty scary. And if you think about a dialysis patient, if a patient has end-stage renal disease, this is a pretty a good article in JAMA, and they looked at basically quite a few patients, 3 million records of end-stage renal disease patient. And they found out that a dialysis patient, once they get major amputation, 1 out of 2 patients will be dead following year. This is scary, scary statistics. That's what we are dealing with, okay? This is a VA study, and if you really look at this data, you'll find that the survival continues to have pretty high, after diabetic foot ulcer is 80%, 69%, and 29% if that wound does not heal. It's pretty damn good data to understand the severity of diabetes and peripheral vascular disease. Now, diabetes-related lower extremity amputation has a leading cause of the global burden of disability. It's now number 10 in a world. If you really look at all the disabilities, diabetes-related lower extremities has a leading cause of disabilities. So what are the predictors of healing in these patients? You looked at the non-invasive vascular studies to really look at diagnosing PVD. We looked at epidemiology. Now, how do you predict whether this diabetic foot ulcer, Mr. Arj's wound, is going to heal or not going to heal? Now, if you think about an independent predictor of healing, they are older age, male sex, heart failure, inability to stand or walk without help, end-stage renal disease, large ulcer size, peripheral neuropathy, and PAD. Okay? The key thing to understand is the predictor of healing differ between patients with and without peripheral vascular disease, suggesting that diabetic foot ulcer with or without concomitant PAD should be defined as 2 different separate disease entities. And look at the statistics. If you have PAD and if you don't have PAD, your chances of this patient's healing is considerably different. Okay. And once if you have infection with PAD, their chances even go down. So that's pretty significant thing to remember, that if you have a PAD, if you have an infection, if you have both together, then that patient have a very poor chance of healing. Now let's look at Mr. RG and try to grade this Mr. RG through Wagner classification. This is our classification that's in our textbook of chronic wound care, where we compare diabetic Wagner grading with pressure ulcer and other venous and arterial classification. And here it is. The Wagner grade 3 is one which is deep ulcer with infection. And grade 4 is someone who has localized gangrene with toe, toes, or heel. So Mr. RG has a severe wound, which is grade 4. It's already gangrenous, it's full thickness, and that's what we are dealing with when we are trying to heal Mr. RG. Now, look at this Margolis data and put Mr. RG, which is our patient, in that perspective. And you'll realize what Mr. Margolis says in 2003 is if you have an ulcer greater than 2 centimeter, if it's greater than 2-month duration, and if it's greater than the Wagner grade 2, the likelihood of healing. So yes, this patient has all 3 risk factors, 81% likelihood of not healing. You see the data here? And that's why we need advanced wound care. 81% chance of this patient's wound is not going to heal. Now let's look at Mr. RG and compare it with what Dr. Prasad said in his initial presentation. Mr. RG has palpable pulse. He has an absent hair up to the middle of the leg. We saw the ABI toe pressures. ABIs are non-compressible. Dr. Prasad beautifully explained why in diabetic patients they can be non-compressible. Arterial Doppler study shows monophasic flow to the dorsalis pedis and posterior tibialis pulse, and transcutaneous oxygen studies show severe hypoxia with no response to 100% oxygen. And MRA and segmental CT angio is not done. So here ABI and the TCOM were compared, as you saw with Dr. Anand Prasad's lecture presentation, and we looked at TCOMs. And here if you compare TCOM and ABI, you'll see that ABI performs very poorly in predicting the healing of foot ulcer and modestly in predicting limb amputation. So transcutaneous oxygen studies definitely predicts both outcomes. And that's an important distinction to make when we are looking at different studies. So Mr. RG, we do the TCOM, we do the oxygen test, and we find at the foot level, there is really no oxygenation. And there is really nothing going on, no response to 100% oxygen. So we are in deep trouble. We already know with TCOM, and this patient has a high risk of amputation. As Mr. RG gets the angiogram, as Dr. Prasad explained to you, as angiogram is the gold standard, and you find what we find typically in a diabetic patient, where you have a good aortofemoral disease, but the disease is below the knee. You see multivessel disease, and really when you go to the foot, there is no blood flow. There is at the mid-foot, there is nothing going on. Nothing going on. This patient is then, and there's a single vessel going right there. There's some collaterals, but this guy has a very, very high risk for amputation unless we do advanced wound care and good limb salvage that Dr. Krishna is going to talk about, vascular procedures. Okay, so what happens is there is an unmet need, and you will find that a lot of people get amputation, as you saw with Dr. Prasad, and 85% of them is preceded by ulcer, approximately 50% morbidity rate within 3 years of surgery. Now look at the survival rate, survival without diabetes, survival in diabetics, and survival in renal failure. We already talked about with the JAMA data before, so it's pretty significant difference between diabetic, non-diabetic, and someone who has diabetes and renal failure. The key thing here is salvage is harder than it seems. If you look at this study, they had 76%, 174 patients who got bypass for ischemic tissue loss, 17 never healed. 13 limbs still required major amputation, BKA or AKA, and 63% of them required more than 3 months for complete healing. And if you look at this wound patients, it took 86 days for those wounds to heal. So we could do better. We can decrease the time to healing. We can decrease amputation, because even with bypass, even by improving the blood flow, these patients don't heal because they have this living paradox, which is microvascular disease that Dr. Prasad already explained it very well, that you can have good palpable pulse, but these patients just don't heal. It's just a living paradox that we live with. Now, Mr. RG got the bypass and you got beautifully good results, but the wound is still not healing and this patient is still having trouble with healing. So now we have to decide whether hypoxia and whether hyperbaric oxygen therapy is useful in this patient or not to help you with healing. And here is the pathway that we have developed to look at which one will be the right candidate for hyperbaric oxygen therapy. As Dr. Prasad explained to you, that we need to have hypoxia, we need to get vascular evaluation, and then you want to do 100% oxygen challenge to see if hyperbaric oxygen therapy is any useful. And you do even intrachamber study sometimes to give a better results. And the study clearly shows that when you do oxygen study inside the chamber, this meta-analysis clearly shows in more than 1,100 patients that if you have numbers greater than 490, then you have 80% chance, 78.3% chance that this patient is going to benefit from hyperbaric oxygen therapy. But if it's less than 100, then only 18% benefited. So again, this is a pretty good data to see that if you do intrachamber study, you have an evidence-based data to suggest that hyperbaric oxygen therapy could be useful. Now, what happens with, a lot of times, as you see, even after inguinal bypass surgery, or if you improve the blood flow, a lot of these patients still require amputation. And then median time to heal is quite high, around 190 days in this study. So, Mr. RG, now our patients, we need to salvage and heal this patient. So this patient gets amputation. He gets empirically started. He has a residual osteo on that metatarsal head, has necrosis. He started on IV antibiotics. Patient was treated for 6 weeks of IV antibiotics, and he was started on advanced wound management. So now patients with like Mr. RG, when do you consider starting advanced wound modalities? And that's what we're going to discuss. And here the data from the consensus statement from American Diabetes Association is any wound that remains unhealed after 4 weeks is cause of concern and is associated with worst outcome, including amputation. So that's when you need to really think about advanced wound management, and you need to think about what kind of advanced management you need to use depending on the healing phase, whether it's infected, what is keeping that wound from healing, what really it needs to start the healing process, what's the wound size, and what is the patient goals. That will decide which technology to use. I can't go in detail about all the technology that's out there with advanced wound management, but I can give you a glimpse of what you can do. If you have an infected or inflammatory wound, you could use pulse lavage, ultraviolet, UVC rays, mist, advanced dressings. If you have a lot of exudates, needs debridement like pulse lavage, negative pressure therapy with instillation. If you have a large and clean wound, needs closure, you can do negative pressure therapy. If you have an arterial insufficiency, diabetic foot ulcer, hyperbaric oxygen therapy. If you want to get good granulation tissue or epithelialization, maybe you can do electrical stimulation, advanced wound dressings like growth factor, collagen, and cellular and matrix product, or called CAMs. So that's something that you could do. This is negative pressure therapy components. That's how, if you order it, this is how it's going to come. And it really helps you to reduce the interstitial edema. It increases the peri-wound oxygen perfusion. It manages exudate to protect peri-wound skin, increases cellular proliferation and protein synthesis, decreases bacterial load, decreases number of growth inhibiting factors in the wound, and facilitates wound contraction. A lot of indications for negative pressure therapy, from cavity wounds to acute surgical wounds, neuropathic wounds, stage 3, stage 4 pressure ulcer, venous insufficiency ulcer, split thickness skin grafts, traumatic wound, and infected wound with infusion. So as you see, there are many, many things that you could do. Hyperbaric therapy is recommended for Mr. RG, as there was no healing. This patient was not getting better, and it's been even with advanced wound care and offloading and nutrition and vascular assessment and vascular procedure. Dietitian has seen this patient. Diabetes has been got into control. Offloading has been done, and wound is just not progressing. So hyperbaric oxygen therapy was indicated. And as you see, hyperbaric therapy is used when you do hyperbaric oxygen therapy. You can do it in a monoplace chamber, like you see here, where you put patient in 100% oxygen chamber environment where patient breathes 100% oxygen, and that's only one person is treated at one time. Or you can do it in multi-place chamber where you have multiple patients, where the chamber is pressurized by air, and then you put 100% oxygen by mask, and you give it to the by a hood, and so patient is getting 100% oxygen under pressure, but the multiplex chamber is pressurized by air, and you have multiple patients treated at the same time. So you will see those two facilities out there, which is much different than, you're going to get advertisement on mild hyperbaric oxygen therapy or hyperbaric oxygen therapy bag, but the data is only for using hyperbaric oxygen therapy, systemic therapy inside the monoplace or multiplace chamber. There is some data on topical oxygen therapy that's coming up, that you can apply oxygen locally on the wound, and but there's no reimbursement at this time. But eventually, probably as more data comes in, that could be another option for advanced wound management where you could use topical oxygen therapy. So here we use negative pressure therapy, we use hyperbaric oxygen therapy, we use negative IV antibiotics, and your wound continues to get better, improves, and you once you get good granulation tissue, you got skin graft or advanced therapeutics to get that wound to heal. There is a lot of advances with skin substitute. It's also called CAM, cellular and matrix products. There are a lot of amniotic products. There are a lot of autologous graft, dermal acellular graft, dermal cellular composite graft, stem cell. It all started in 1988 with introduction of AAPI in burns. In 1998, the first APLIGRAFT, which was first tissue engineered product to be approved by FDA. In last 15 years, there are multiple different skin substitutes out there. There's and that's why it's called CAMP, cellular and matrix product. These are great innovative products. It works great on a selective patients, but there is a lot of overuse and there is a lot of abuse going on with this in the wound care industry, and Medicare is definitely looking at it. There was an article in New York Times, and there is a program called WISER, Wasteful and Inappropriate Service Reduction Model, and CAMPS is one of them, which they are going to look at it to make sure that patients are using this advanced wound therapeutics appropriately. All right, so Mr. RG does get healed by everything we do, hyperbaric oxygen therapy, negative pressure therapy, and CAMS, and wound completely heals, and then you do orthotics and get them to heal. I may have 5 minutes to just talk about what we can do if we get limb salvage. If that's the goal, then you need a team. And when you want to create a limb salvage team, like what Dr. Prasad is trying to do at University of San Antonio, is basically you're going to need a minimum a good vascular surgeon or a cardiologist with endovascular training, because no blood, there is no healing. Okay, you need podiatric surgery to optimize biomechanics, offloading, and you need key adjunct staff like wound care, plastic surgery, hospitalists, infectious disease, nurses, PAs, NPs, prosthetics. So you're going to need a whole team if you really want to do a difference and if you really want to do a limb salvage. And these are a few more people who can get involved: physical therapist, chaplain, case management, social worker, infectious disease consultant, that can help you to get them a better results. Now, the key thing is a lot of times, the treatment with limb salvage is very fractured. A lot of people are not working as a team. And what we have found in the program that we developed in the past is when people start talking to each other and when we are all in one page, whether it's a cardiologist or a vascular surgeon, whether it's a wound care doctor or a hospitalist or emergency room doc or an infectious disease doctor, when they are getting paged, like when someone gets a chest pain, you get a common page and the chest pain team arrives in the ER and things gets done. The same thing we need to do with a limb attack. You need to get people all getting same page, going and attending that call in ER at the same time so that we can decrease. And that's what we found. When we implemented this limb salvage in our hospital, when everybody there was no ambiguity who to call. Everybody who was needed are getting called at the same time. And then in 24 hours, we got vascular surgery involved, podiatrists involved, wound care involved. You get immediate, all the vascular testing that Dr. Prasad talked about. And we got evaluation by wound care for TCOM and hyperbarics, immediate out or communication, getting social worker, dietitian, and hospitalists involved, getting education to everyone helped us to successfully do this. And when we get this done, we decrease the length of stay, decrease the readmission, and decrease the amputation. And there are a lot of data out there. This is just one of the protocols that we thought it's very important for all of us to have if we want to develop limb salvage teams in our hospital, is to be able to get this collaboration done early on. This is what we recommended for our hospital, how we can, what will be the scope for each section, and who are the team members who needs to be involved, what is the diagnosis in ER that requires that common limb attack page, and what are the initial labs and the diagnostic that ER physicians should order if this patient comes in emergency room with this problem, which you could expand to outpatients also. And that's why we developed this protocol. And then that is the basically call to action, as you see that yes, amputation rate is going down, but it's still not at the level where we feel that our patients are getting the best care, because we think amputation should be one of the indicator of healthcare delivery in our country, because like maternal mortality rate, we should be measuring amputation to see whether every patient is getting good quality care. Because if Mr. RG does not have a leg to stand on, then whatever we do, whatever advances we do, has no meaning. So unless we come together, work with compassion, love, and understanding and oneness, otherwise it's only techniques. You can improve the blood flow, you can do a great angioplasty procedure, but there is no healing. And that's why we need teams. So our goal in conclusion is the standard wound care to promote a normal wound healing environment. When healing fails to progress normally despite adequate standard wound care, then advanced wound care modalities are considered, and advanced wound care should be considered only in conjunction with standard wound care. There are a lot of advances out there, but none of this advanced wound product will work alone. It has to be part of a comprehensive standard wound management, working with your vascular surgeons, with your cardiologists, and with a limb salvage team, with your podiatrist for it to work. So I'm going to end it right here, Dr. Nerovelta, and I will be open to questions during the panel discussion. Thank you.
Thank you, Dr. Shah, for that excellent talk. And so then we will move on to our final talk of this session for our Limb Salvage Summit. And so it is my pleasure to introduce Dr. Krishna Manava, who is an Ohio native that I've known since I was a child, actually, and is also an alumni of my alma mater. He's been a practicing vascular surgeon for 18 years. He was previously at Loyola University in Chicago, then Fairfield Medical Center in Lancaster, Ohio. And in 2020, he opened up Vive Vascular Center and then added Trillium Surgery as an ASC in 2024. So without further ado, I will turn it over to Dr. Manava.
Okay, thank you, Soumya. Very nice of you. So before I load my talk, this is the problem with going third. When you follow people like Dr. Shah and Dr. Prasad, who are geniuses, I don't have anything left to talk about. So additionally, I'm a knuckle dragging surgeon, unlike these guys who are extremely intelligent. So I think I'm going to cut out half of my talk and we'll get to the heart of it and sort of share my insights in the mind of a vascular surgeon or a vascular specialist. And my job is to deliver the flow, obviously, to the toe so that guys like Dr. Shah can then save the leg. So let's see if this works here. Hold on one second. Okay. Okay. Hopefully that works. Okay. So let's skip ahead. I'm going to skip through all of this stuff about PAD. Just to reiterate, PAD and critical limb ischemia are often under talked about as diseases. Stroke, breast cancer, prostate cancer get all the hype and publicity. No one talks about CLI and PAD when we all know the mortality rates are astonishing, especially with CLI. So I think Dr. Prasad already said CLI as a end of PAD or on the spectrum of PAD is only about 5% of PAD patients. And he said something very important. That small percentage is the reason why we don't over aggressively treat PAD when it's non-critical limb ischemia. But when we develop CLI, we have to throw everything at it, from a revascularization standpoint to wound care to everything we have. So what I really want to focus on today is the incidence of below the ankle disease. 8 to 10% of PAD involves significant inframalleolar lesions. And this is often part of multi-level disease. And I think as Dr. Prasad and Shah said, there is a significant correlation with diabetes and renal failure. So in my practice, majority of my patients have some degree of diabetes and renal failure, and I treat a lot of end-stage renal disease. 40 to 50% of my practice is dialysis access. So we do uncover a lot of critical limb ischemia in our dialysis population. So when we talk about levels of PAD anatomically, the traditional levels are inflow, meaning aortoiliac disease, femoral popliteal disease, which we typically see in smokers, claudicants, and then what we see in our diabetics and renal failure patients are infrapopliteal disease. But I propose a new level of PAD that's gaining more and more interest, and that's below ankle or inframalleolar disease. So just basics on the anatomy, Dr. Prasad touched on this, but real basics, popliteal artery, and then the 3 tibial arteries below the knee. But what's really important is when we look at those tibial arteries, they supply 6 distinct angiosomes. So where the wound on the foot is, whether it's on the heel, whether it's at the tip of the toe, at the metatarsal head, all falls into angiosomes. And I put this together in my mind when I decide on revascularization strategies. As you can see, the anterior tibial has 1 angiosome, the peroneal has 2, and the posterior tibial actually has 3 angiosomes. When we look at angiograms and we look at anatomy, we often sort of don't look below the ankle traditionally, but we are now. And when you look at the termination of the anterior tibial artery and the posterior tibial artery, we can now see there's a lot of connections that happen below the foot. And these anastomotic loops or collateral pathways in the foot really provide us avenues for revascularization. And probably the most common one, and one I'll talk a little bit about, is this pedal plantar loop, meaning the connection between the posterior tibial artery, sort of the lateral plantar artery, up through the foot and communicating with the termination of the dorsalis pedis artery. These have been described, the pedal arch in Japan. A type 1 arch is a complete pedal arch. A type 2A is where the AT and the DP are open. A type 2B, the PT and plantar arteries are open. And in the type 3 arch, both the DP and the plantars are occluded. So this just helps us classify disease and how difficult revascularization may or may not be. When we talk about direct versus indirect revasc, direct revasc means we just get blood flow down there. We don't care what vessel we're perfusing. We just are trying to overall increase flow to the foot. Sorry, that's indirect revasc. I'm sorry. And direct revasc is more targeted. So we really want to direct flow to the angiosome with the artery so we can perfuse that wound directly. So there is a correlation with higher wound healing with direct revascularization. And while still good, indirect revascularization is not necessarily as strongly correlated with wound healing. Another thing we look for is a wound blush. When we are revascularizing a leg on angiogram, the presence of a wound blush after intervention is associated with a higher perfusion pressure, and it may serve as an endpoint. It's not the only thing we look at. I mean, if you look at this patient on their angiogram, they've got a wound blush at the wound. If you look at the picture of the wound, but the wound wasn't healing despite months and months of wound care. But you can see their plantar arteries are occluded. And once their plantar arteries were revascularized, the wound blush became more prominent and the wound did ultimately heal. So my strategy as someone charged with restoring flow is I fix the inflow. And inflow isn't just aortoiliac, it's all the way down to below the knee, to the level of the distal leg. Then sort of regroup, reassess clinically, ongoing wound care is happening. And then if needed, we stage a more distal revascularization. And oftentimes staging is needed because access and approach is different. And this requires sometimes antegrade access, sometimes even antegrade access in a tibial vessel, sometimes pedal access, sometimes even interdigital access as far down as the toes. Non-invasive workup, which Dr. Prasad touched on, is obviously it goes hand in hand. Arterial duplex ultrasound is great down to the level of the ankle. Toe pressures add to the clinical picture. Pedal acceleration time is gaining a lot of popularity, especially post-intervention. I still emphasize physical exam as key in addition to the non-invasive workup. If I can't palpate pedal pulses and there's still signs of persistent wound non-healing, I have a low threshold to repeat angiography and re-intervene. So I touched on it already, but indications to go very distal are continued CLI despite optimal inflow. I just wanted to dive a little deeper into the pedal plantar loop technique. So this was developed overseas in Italy and Asia. It had been performed in more limited numbers in North America, but it has been rapidly gaining support. Here's a case example. This patient is a patient with a non-healing wound, and you can see very, very sparse perfusion to the midfoot and out to the digits. So the way we would attack this is going down either through the anterior tibial artery and then around the pedal loop, or down the posterior tibial artery and around the plantar pedal loop. Either way, or sometimes both ways. And here's a case example of this same patient. And you can see guide wire access all the way down and around and up the AT. And then treatment consists thereafter of either angioplasty or a form of atherectomy in conjunction. And there's a completion angiogram. This was a case from Italy, and you can see the tremendous tissue perfusion that occurs after this. Alternative accesses, which I just touched on, can include antegrade access at the groin, antegrade access at the distal leg, retrograde access in the foot or at the ankle. Here's an image of, a dorsalis pedis access here. And a lot of this is derived from the popularity and success seen in radial access interventions for coronary. Here's a case example of an antegrade posterior tibial direct stick access, along with a transfemoral antegrade access with catheterization in the anterior tibial artery to reconstruct the plantar pedal loop. Other techniques we use to cross some of these lesions, there's things like the safari technique, where we're going from below the lesion and from above a lesion. Typically, these are very, very resistant lesions to crossing. And so we've got to sort of use everything we can to get through the lesion. Sometimes we go subintimal. And again, this is another technique, the CART technique, with a controlled antegrade and retrograde subintimal tracking. And then there's a reverse CART technique. Another thing that I really just want to touch on lightly is also gaining popularity, deep venous arterialization. So if we can't or we fail to restore flow from the arterial side of the wound, well, there has been actually surprisingly good success with perfusing the wound from the venous side. So somewhere upstream, we're able to traverse from an artery just above an occluded tibial artery into a deep tibial vein. We break all the valves in that vein and then restore arterial pressure into that deep vein and then down into the foot and reperfuse the wound from this direction. So this has had almost 2/3 of patients with basically no other option have wound up with wound healing and limb salvage. Medication adjuncts to what we do from a surgical or endovascular standpoint are critical. And then I just want to touch on that post-procedural follow-up is extremely important. These vessels reocclude, they restenose, and I have a very low tolerance to reintervene and keep the flow going. These tibial arteries are just stubborn. So this is an example from a couple years ago. 84-year-old female, diabetic, smoker, AFib, all the typical comorbidities we see, that developed a heel ulcer after a fall and hip fracture. 3 months of wound care, multiple debridements, antibiotic therapy, still no healing. Here's a picture of this patient's wound. She had an overall well-perfused foot, a palpable dorsalis pedis pulse, but this wound was just not healing. So here's the angiogram on the left, and you can see pretty strong flow down to the proximal leg. And there's many vascular specialists that kind of say, hey, look, there's nothing more we can do. There's flow to this. I can't do anymore. And if you even see the foot angiogram, this anterior tibial artery all the way into the foot looks great. Most in the past, historically, most endovascular vascular surgeons would just say it's done. I can't do anything more. But we know that more can be done. So I attacked this posterior tibial artery because, thinking back to where the angiosome of this wound was, I had to get flow to that calcaneal area. So I could not cross this from above from an antegrade approach. So at this point, we decided, let's go through the AT, go traverse this pedal plantar loop up the lateral plantar artery, and then try to cross this posterior tibial artery occlusion from below and from above. And you see, ultimately, we were able to cross the lesion and then treat it. And Here's a completion angiogram on the right with direct flow down that posterior tibial artery into the plantar arteries and all these vessels around the calcaneus, ultimately giving this lady a chance to heal her wound. I talked about follow-up on these patients. They have a high risk of restenosis, so we have them on a very strict imaging schedule, as well as frequent office visits and close physical exam. Just to summarize again, 10% of CLI cases involve treatable below ankle disease, but now we have strategies and tools to continue to treat these more and more aggressively, but it requires persistence, relentlessness, some risk taking, and willingness to treat these. So I just threw in a case. I just last minute. This was another lady I treated last month. Presented. She's a former smoker. Had a tight irregular iliac stenosis. Wound up trashing her foot. I treated the iliac stenosis with a stent, but her foot did not improve. And you can see the rapidly progressive infarcting tissues of all of her digits. And this was her foot angiogram from, basically the atheroembolus that occluded everything in her foot, basically a desert foot. So we had to really give her everything we could, or she was going to wind up with a BKA. So we did a plantar pedal loop technique. We're pre-dilating it. I think I may have used laser atherectomy on her in addition. And this was the completion result. And you can see the plantar pedal loop reconstructed. Now, there's some foot movement, so I don't have some better delayed imaging to show you the perfusion that did result. But there you can see her foot is hyperemic, warm. This was weeks later. And the tissue loss has demarcated to the very tips of her second, third, and fourth digits. So, and pain-free. So really good chance for a limb salvage with her. I'm going to end the show and try to show, if I can, let's see if this will work. So you may have to help me. Let's see. Okay. Can you all still see my screen? If you can, some of you give me a thumbs up.
I can see your screen, yeah, and it looks like it's loading.
Okay. I don't know if the audio will come through. This is a 39-year-old diabetic, occluded DP, occluded PT, had a really, really dense calcified rock in his dorsalis pedis artery. I could not cross this for the life of me. From an antegrade approach, I tried to break the calcium with a needle directly. I tried multiple things. I could not break this. My needle basically fractured. I stuck distally. Here's the angiogram. You see the foot lighting up when I stuck distally and injected, but I could not cross this DP lesion from either way. So at this point, what do? Sometimes as surgeons, we have to get really creative. So on this patient, I cut down on his dorsalis pedis artery, did an endarterectomy, and you can see that nasty, nasty calcium. There we've got a target back bleeding from his distal DP. I did an endarterectomy, then I wound up patching the entire vessel. There's a cleaned out artery, patched the artery, and there's a close-up of that. There's his two toes. You can see here's the Doppler. I don't know if you can hear this. And there's the closure. So he wound up losing just the tips of those two digits. So anyway, so sometimes endo treatments are not enough and we have to resort to good old-fashioned surgery as well. But I think that's the importance of having an endovascular team, including surgery and including all the minimally invasive techniques we have.
Thank you, Dr. Manava. That's another excellent presentation. We have several questions lined up. And so I think the first question is actually one of the questions I was going to ask. And I would think is directed to I think all of you, but we'll start with Dr. Prasad. Dr. Paul had the same question I had about prevention is better than the cure. And so what are your recommendations that you give to your patients specifically? I mean, we can say things that are global and non-specific, but what are the specific things, not just a general comment about reducing risk factors, et cetera, but what are the specific things that you talk to your patients about, and you would advise other people to talk to their patients about to reduce their risk of developing critical limb ischemia?
Yeah, I think a lot of this is who is likely to develop critical limb ischemia. We know that as many as 1 in 4 patients with diabetes at some point in their lifetime may develop a diabetic foot ulcer. So, if we don't talk to them about foot care, neuropathy, prevention of micro and macrovascular disease, then we're doing a disservice. If all we're telling them is to lower an A1C value and we're not telling them why, I think we're doing a disservice. So I really bring in amputation risk, PAD, neuropathy early on into the conversation of my patients. They may be seeing me for heart failure or chest pain or dyslipidemia, but I kind of link why we're so obsessed with lowering the A1C, why we're focused on that rather than just targeting a number. So you have to give them clinical context on why you're targeting cardiometabolic disease.
Thank you. I think what I would add to that, as someone who sees a fair number of these patients as well, is when we're talking about prevention, I think sometimes if we're really talking about prevention, we need to even try to prevent it even before we get to the diabetes, right? And I think we need to be talking to patients about hypertension, low sodium diet, and of course, tobacco cessation. And I think we all probably spend a fair amount of time getting our smokers, or the patients that are smokers, to spend a lot of time with tobacco cessation. But I think a little bit more awareness about the prevention of hypertension and treatment of hypertension is important as well. Dr. Shah and Dr. Manava, anything to add to that?
No, I think, I think that typically what we recommend is the primary care doctor work on, because when they have peripheral vascular disease, most likely they have coronary artery disease too. And, by the time they come to us, they have multiple things going on. So the prevention, as you said, has to start early, when the patients are seen by primary care, even before the diabetes and hypertension starts. But still, our goals remains the same. Trying to make sure the blood pressure is less than 120, and by 70 their LDL is less. So our goals are less than 70 with our peripheral vascular disease, at least LDL over there. And then we try to see if their HDL can be increased, So we talk about that A1C, as you said, less than 7. But the key thing is, by the time they come to us, it's pretty late. By the time they get gangrene, and then requiring amputation, it's pretty late in the game. But still, prevention talk always works.
Krishna, did you have anything to add?
No, I totally agree with all those comments.
Okay. So post-procedurally, so I guess I have a two-tier question. The first is, what advice do you give to your patients to get, the best outcomes from the procedure? And Krishna, you touched based on this a little bit. So to dive in beyond like the first part of the question, I'd like to have a follow-up question there, is you mentioned your post-surveillance routine. And so I'm just curious if you could just detail that a little bit more. How often are you using like a duplex to surveil them? And how often are you doing that?
Yeah, so my thoughts are it is tailored patient to patient, how severe their and critical their tissue loss is. But I see them usually within 10 to 14 days with some sort of vascular imaging, non-invasive imaging, physical exam, obviously. But I make sure the ship is loaded. If they don't have a podiatrist, if they don't have whoever else, what other specialist, wound care specialist, whoever, I make sure that they have the whole team. And as I made some of the comments, a village, you really need a village for these people. So I also lay this foundation in their mind that for me, I like, if you have cancer, cancer can recur and it's a lifelong management for many cancers. I said you have to look at peripheral artery disease and critical limb ischemia like cancer. It's not just one or two treatments and you're done and you're cured. So I have to pound this into their brain that this is going to be a lifelong problem. We have to stay honest. It can recur just like cancer can recur, and we oftentimes have to retreat when it recurs. So I sort of lay all this into them, and I tell them it's a long journey. This is not going to heal, as Dr. Prasad and Shah said, it's not going to heal in a month or two. This could take a year or longer to heal, depending on the extent of tissue loss. So it's sort of a psychological therapy in addition to some of the testing and physical exam.
Yeah, I think Dr. Krishna says it correctly. And Dr. Armstrong, who's big in, he has correlated diabetic ulcer like cancer and say, when you heal it, they're in remission. They're not done. They kind of, he has used the same terminology like cancer terminology. Like, when you heal, you don't call it, you're done, you're in remission, it can come back. So you need to still do the prevention. You need to still do the offloading, continue doing diabetes management and hyperlipidemia management. Yeah.
And then what is your standards, I guess both Dr. Prasad and Dr. Manava, for post-op medical management in terms of DAPT, aspirin, alone, DOACs? Which way are you leaning and what is your
Right.
recommendation?
So, patients need to be on either antiplatelet or antithrombin therapy once they have an established diagnosis of PAD. If we do an intervention, some of that's determined by the technology that we used. If we use drug-coated balloons, a drug-eluting self-expanding stent, let's say in the SFA, or a bioabsorbable stent like the Abbott stents below the knee, some of that is mandated by sort of the trial data to use dual antiplatelet therapy. In my patients, have a very low threshold to use low dose rivaroxaban for antithrombin benefit, and coupling that with either monotherapy with Plavix or aspirin. So we try to be aggressive and target both the antithrombin as well as the antiplatelet pathways on patients. Those who get drug-eluting technologies, I tend to use dual antiplatelet therapy or Plavix plus rivaroxaban.
Dr. Manava, did you have anything to add to that?
No, I totally agree with that. That's well said.
Okay. So backing up a little bit, I was just curious on when you get a referral for a patient with a wound, for example, what's your kind of algorithm on imaging procedurally before you do the angiogram? Do you get a CTA on all your patients? Is a duplex enough? And another way to look at it is, what do you wish a referring physician had done imaging wise before they send them your way?
So, I think Krishna and I can probably take that on. My approach, what do I wish the referring physician? I wish they would have not waited for imaging and all sorts of stuff, just sent the patient, because sometimes, maybe they order an ABI and by the time it's approved and the patient goes and gets it done, and then they're coming to you, 4-6 weeks have passed or whatever, and you lost valuable time. So I'd almost rather just get them without an ABI. In my talk, I showed you the limitations of the ankle brachial index. We still get an ABI, but I've done angiograms without an ABI. Like, I just look at the patient, look at their history. So my threshold to do an invasive angiogram is very low when I see patients with diabetes and tissue loss. The CTs I use a lot of times when patients have bilateral symptoms, aortoiliac disease, to size the aorta, size the iliacs. that's particularly helpful. Tibials, I don't really use CT scans for tibials much, largely because these patients have so much calcium. I don't know if it's just calcified or is it occluded, and you really need more sensitive angiograms. So, I have a low threshold for angiography, CT for aortic disease, and then I use duplex imaging post revascularization to look at peak systolic velocities.
Wow, this is like talking to a mirror. I totally agree. Uh, Timeliness of the referral is the main thing. I could really care less if any tests are ordered. I mean, if there's a wound, a critical limb ischemia suspected, I think um, getting to us as fast as possible is essential. I don't order CTAs for a couple of reasons. We're trying to eliminate as many barriers to getting treatment for some of this patient population. So saying, oh, you've got to go to this imaging center, you've got to go to the hospital, get a CTA, when we know based on what we're seeing in the office and based on non-invasive exams in the office where the disease is. So I try to eliminate as many barriers as I can, unless there's aorta-iliac disease, then I think a CTA is super helpful. But so that's sort of my strategy, is I have very less low threshold to jump right to angiography. And the other factor, which we don't really talk about, is all the hurdles with getting prior authorization for all of these non-invasive tests. It's a pain it's a pain. So just kind of circumnavigate all that stuff that we have to deal with prior authing as a CTA.
Sure. Well, to follow up on that, have you had any issues prior authing the angiograms, especially with your surgery center?
Yeah, yes. They're dealing now with these third parties who are now handling prior auths and all that. It is a pain. So our documentation has to be sound, but for the most part, with good documentation and definite critical limb ischemia, fortunately, we've been able to really not have too many delays with that.
Okay, thank you. So now segueing, there's a few questions that are a little bit more wound care directed. So Dr. Shah, there was a question specifically about your machine. So what machine model number do you recommend for TCOM evaluation in the lower limb?
There is a lot of upgrades with TCOM now, and so now you can do like what you saw in the picture where separate channels. Now you can have 6 or 8 channels together. TCOMs are mainly done by 2 companies, and because this is CME, I won't give you the company names, but if you private message me, I'll give you the 2 companies who make TCOMs.
Thank you. And there's another question about how long the hyperbaric therapy, the duration of the therapy, and the frequency.
Well, usually Monday to Friday, usually the dose is 2 atmosphere. We consider oxygen as a drug, and so we want to use it in the right dose. So 2 to 2.4 atmosphere Monday to Friday. Typically 30 treatments is what we recommend. If it doesn't work, and that's why in our protocols, you have if your chamber number is less than 100, then you only give 10 because that's just a trial. And if your oxygen number is not going up in the chamber, then probably it's not going to work. So earlier you do amputation is better on those cases, but at 30 is what we recommend, and that's when utilization review starts at 30, and you want to make sure that you're using it appropriately every 10 treatments if you are increasing HBO at 30 to 40 treatments. But that should be 30 to 40 is usually what we need.
Excellent, thank you. And then I had a question for you. It's not specifically to critical limb ischemia, and maybe not even specifically to PAD, although I do think the PAD plays into this. But in the current era where there's so many dressings now, what is your go-to starting dressing if there's just like a poorly healing, like surgical incision, for example, Mepitel, I mean, there's so many options. We could spend all day on that, but I'm just curious what your go-to dressing is right now.
Yeah, I think that's always a good question, and it's like what will be the go-to vascular procedure? It's like so many different ways you could do things, and it depends on the kind of the wound you will do it. So it's very difficult to answer that, but if it's a simple surgical wound, you're trying to keep the wound moist, or if you have a surgical incision, you're basically using a non-adherent dressing to cover that, and then you're covering with silicone-based Mapilex dressing. Those are kind of my favorite ones because it doesn't adhere to the skin, so you can take it out. But the wound care is such complex, like you have 4,000 to 5,000 dressings. And but it comes in categories. So if you can simple, less costly dressing, which you could use if you want to have a wound where you want to just keep the moist environment, will be just hydrogel, right? And then if you have a wound which requires debridement, and if you can't do it with sharp debridement, you still need you can use enzyme debridement, or you can do autolytic debridement. Enzyme debridement, there are a couple of them out there. Collagenase is there out there, and there's a new bromelain base which is going to come out. And then if you have a lot of exudate, then you divide it. Basically, if it's infected, then you're going to use, and if it's acutely infected, sometimes I will use things like acetic acid also, because in hospital, if they have purulent drainage, acetic acid or Dakins is fine for short time, but in long term, it can be cytotoxic. But if you have, you can use, if it's just a biofilm, a little infection, which is not letting the wound heal, you can use silver dressing or antibacterial foam dressing to help with exudate management. And then if your wound is not exudative, it's a mild to moderate, but it's clear, it's not infected, then you can go to multiple collagen dressings that's out there. And if you have some wound which has drainage, but it's really not infected, but a lot of drainage, you can use calcium alginate. Sometimes you combine them with alginate and foam dressing. So, if you have neuropathic diabetic foot ulcer, you will use a growth factors. So, and there are a lot of combinations available. So that's why, as I said, there are more than 4,000 to 5,000 categories. But if you are a simple office person who is handling the wound care, then I'll keep one hydrogel, I'll keep one collagen dressing, I'll keep one calcium alginate, and I'll keep one foam and a Mapilex silicone dressing to cover it. So I think that's 4 or 5 dressing. I'll keep it if it's an office based, or if you're a vascular surgeon who wants to do a little bit of wound care, then you could keep those few dressings in your disposal.
Thank you. That was very helpful. I think that was all of the questions. Oh, I think someone asked, what were the indications to order an angiogram? And I think we responded to that in the chat, but since I don't think we answered that verbally, Dr. Prasad and Dr. Mandava, do you want to hit that one?
Yeah, I mean, I think there's some limited data out there, but I feel like we wait too long to look for peripheral arterial disease, or we get reassured by, again, ABIs that are maybe look or appear normal when we know these people have a lot of tibial disease. So with tissue loss, I would push for an angiogram very early in the process. Claudicants, we need to be a little more thoughtful. Continue smoking cessation, walking program, but things like rest pain or tissue loss, I'm much more aggressive up front with an angiogram.
Yeah, totally agree.
I feel like that's going to be Dr. Mandava's mantra. There's one other thing that that we did not hit on verbally as well. Someone asked about the correlation of CAD and PVD. Why is there not 100% correlation between the two? And I know you commented on a little bit on the chat, but I think it's worth discussing that a little bit as well.
Yeah, I mean, I think coronary disease can be genetic, it can be related to dyslipidemia, uh, and PAD is larger vessel disease, smoking, diabetes, chronic kidney disease in particular. But I think we underestimate the true prevalence of PAD. In the study where we looked at subclinical PAD in the South Texas population, we were up to almost 20% in the general population, and these are asymptomatic, free living people, similar to a Framingham cohort. So I think if you took people with coronary disease or other vascular beds that had disease and then looked more specifically for PAD, and looked at their tibial vessels, we would find advanced atherosclerosis in many people with diabetes who have no symptoms. Tibial disease is asymptomatic until it isn't. So I think those numbers would be a lot higher for correlation.
Agree. Dr. Manava, anything to add there?
No, I defer to our cardiologist on that one.
Okay. I have one that I'm going to direct at you, Anish, at first, though. How hard is it in very obese diabetic distal limb ischemia patients to do their limb management? And is there a different strategy in these obese diabetics?
So yeah, there is obesity, especially when I'm treating them in an outpatient setting, whether it's a surgery center or an office-based lab. Managing access site complications in obese patients can be extremely challenging. So alternative access, whether it's pedal access, whether it's radial access, things like that, really help managing those patients. And our diabetics tend to have sometimes smaller vessels. So smaller and smaller access sheaths, smaller and lower profile balloons and devices really help also in managing these. So it is a challenging population, whether it's in Ohio or whether it's in Texas. But yeah, I think alternative access sites and being very thoughtful and selective about device usage.
And just to follow up on that, so with the increased use of alternative access, what percentage of your cases are now being done with a radial or pedal approach as opposed to a femoral approach?
I rarely do radial unless it's for some sort of upper extremity or proximal disease or there's something, just because it is tedious and it is awkward. So I will do still probably 60% transfemoral, 30% pedal or plantar access, and maybe 5 to 10% radial.
Dr. Prasad?
Yeah, I mean, I would agree with that. There's been such an advance in radial approach in the coronary world, and it's really lagged in the peripheral arena. We have some stents that are long shaft, some catheters. We have one long atherectomy system. We can get some IVL therapies, but you begin to really run into limitations. Generally you're using the left radial to do work so you can get more length. And then, you certainly don't want a very tall patient. And then if you have a complication, the bailout strategies are more limited, if you're radial. So the industry has not moved enough in the radial arena. We're just not there. Yeah.
Yeah, and so in my experience, I definitely prefer radial to like an antegrade femoral, and especially is because I feel like almost all my patients are obese, so to some degree. So in terms of vascular complications, it's simpler, but it's certainly a little more tedious, requires a little more patience, and the equipment is certainly, more limited.
Think
Uh,
so. I mean, I think one to add to that, I think radial is nice for those, but those cases where suddenly you've intervened and there's no flow or there's clot
yeah.
and you're at a radial, like Dr. Prasad was saying, it's like, oh, I mean, a lot of four-letter words get thrown out. And so that's another reason why femoral access is really helpful. In some of these obese patients, I will go proximal SFA access
Mhm.
just to avoid the pannus, and then using some sort of closure device or something, if possible. But proximal SFA has become more popular for me.
Yeah, I mean, the first couple of centimeters of the SFA are generally attractive. We certainly avoid going more, at least I do, more, I guess, distally in the thigh, because if your closure device doesn't work, then, you can get a compartment syndrome and stuff. So.
And you're using that retrograde still or antegrade?
No, antegrade. I mean, antegrade for me, when possible, is very valuable. I mean, with a 5 French antegrade sheath, you can have so much more support, pushability, CTO crossing. You can fix multiple vessels. So if you can get a wire down the PT-AT through one access. And then, if you're using the new sort of shockwave techno or IVL technology, the little crossing device, it's much better through, an antegrade access.
And then I think the last question is, what is the incidence of pedal occlusion in pedal approach?
So, this has been looked at. It's actually quite low. If you're anticoagulate appropriately, use vasodilators. Even on our completion angiograms, oftentimes I'll aspirate from the sheath as I inject from above, to help with augmenting flow. You might actually get a lot of spasm afterwards, and maybe the pulse is not that good. You come back, 30, 40 minutes later, Doppler it, you got a robust pulse. And then these patients, when we re-angio them, everything looks good. So I think the keys for pedal occlusion, avoiding pedal occlusion, is ultrasound guided access when possible. I still favor a front wall stick. I use copious amounts of vasodilators, and I anticoagulate with ACT, pretty high, so 250 to 300, and use hydrophilic sheaths, so 4 or 5 radial sheath or 4 French hydrophilic sheath. At least that's what I do.
Yeah, I would agree. Surprisingly less access site occlusions than I would have expected with pedal access, but there are some that happen occasionally. And so when that pulse doesn't return, we have a low threshold to re-angio them from a proximal access and maybe balloon angioplasty, that vessel back open. And so usually you can get out of it if it does occur, and it's a critical vessel that's needed. But yeah, I would agree. There's another strategy, obviously, when you're exiting, you can't just hold direct pressure on the artery like you may on a groin. So there's some subtle nuances to the way pressure is being held, or whether it's some sort of external pressure device, but not to focally re-occlude that vessel and risk it thrombosing.
Okay, well, if there's not any other pressing questions, I think we should let people get back to the Diwali celebrations a few minutes early. So I will turn it over to Dr. Chakrabarti if he is still logged in. Just checking to see if he's on. And I think he had to, oh no, he is. I'll try to unmute him.
Yeah, I was
Okay.
I was muted, so I listened to the whole thing. It was an amazing session. It's just, I know that Diwali celebrations coming up. Today's Choti Diwali, tomorrow is Diwali. But I know people have engagements. We have had conflicts with cricket matches. We have had conflicts with somebody's wedding. So we decided to keep each Sunday of each month specifically for each program. So that's the reason we have had third Sunday of every month, so that people don't, even if we send them the notice of the CME late, which sometimes happens when we try to get speakers, that doesn't interfere with them. There's a set every third Sunday, 2 p.m. Eastern time, we will have so we we cannot cater to. I mean, suppose it falls before Diwali, it's there. You cannot make it. We understand. There are 16,000 members and only 45 and 50 attended today. We do not get more than 100 anyway. So we have to deal with whatever we can. And I'm sorry about the timing. The speakers did such a great job. But more importantly, this talk is going to be is recorded and it's available on the website. So anybody who could not attend because of certain obligations, they can always access this on our website. Every CME which people have missed and wish they had not missed is going to be accessible on the website. By the way, the CME time of being of 2 hours is something which the members have requested. They want this to be, they want 20 or more than 20 or 22 CMEs for the year. And if you just give one CME, 1 hour CME, they only get 10 CMEs for the whole year because we don't do it in 2 different months, the convention month and the global summit month. We usually don't do the CME. So that's the reason we've kept it for 2 hours. And we literally needed this to more than 1.5 hours to listen to these excellent presentations. And that's the reason we have to listen to the consensus and we'll go. If it is going to be in, sometimes it'll clash with Christmas Eve, sometimes it'll clash with Pongal, Sankranti, but we or Navratri. So we will keep it on the third Sunday of each month at 2 p.m. Despite Garba, Navratri, Durga Puja, whatever it is, it will be held on this particular day every month, unless there is some dire situation, like if you have got the convention going on or global summit going on. So thank you so much for your attention. Next month, again, third Sunday of next month, we will have neurology. We'll have a very good neurological topic on stroke. So please try. It'll be again. It'll be for people who are very. I mean, it's not going to be neurology specific. It'll be all specialties. Anybody who's attending will it from top, and next time we can do this. I hope more people can join, and I appreciate your joining here. And we will see you next month. Don't forget, next week, we have a talk on H-1B visa issues, where Dr. Bobby Mokamala, president of AME, is going to be there. We are getting a congressman, and we're getting somebody from an attorney from New York who deals with this H-1B issues. It's going to be a very eye-opening talk. So usually, and so our talks are usually first weekend we do legislative coffee with the senators. Second weekend we do sponsored talk. Third weekend is CME, and fourth weekend talks, which is of general nature, like H-1B issues, like any other, billing issues, et cetera, something which comes up to try to address this. Thank you for your attention. Over to you, Soumya. Thanks a lot for attending.
Thank you to everyone. I really do appreciate everyone taking time over the holiday weekend with us. And thank you to all of our wonderful speakers, Dr. Anand, Dr. Shah, and Dr. Mannava. And thank you, of course, to Dr. Chakrabarti and Dr. Vasavada for this opportunity. So without further ado, I bid you all adieu.
Thanks, Soumya.
Thank you.